and then I will start to introduce for you operations in the neck region. I will tell you that generally there are 4 groups of operations. Operations on the organs, operations on the vessels, operations on the nerves, and operation in the case of the purular processes. So then you make operation in the organs of the neck. This triangle is the most important for you. Why? Because it contains all organs. As you remember, all the organs located below hyoid bone, strongly by midline, and strongly by midline below hyoid bone, we have omotracheal triangle. That is topographical specific. Okay, first organ which I want to introduce you, this is the thyroid gland. Long times before my class, during different subjects like histology, like anatomy, like physiology, you spoke about this organ. I want to remind you that this is endocrine gland. It is one of the most important endocrine glands because it is making the regulation of many functions of the human body, starting from developmental functions, metabolical functions, cardiovascular regulational functions. That is all in the work of this gland. How it is regulated, the functions, of course, by production of the hormones. T3 and T4, that is 2 main hormones of the thyroid, also calcitonin. T3, T4 produced by follicular cells, calcitonin produced by parafollicular cells, as you remember here. By the way, calcitonin, it is the antagonist hormone to the parathyroid hormone, which is also, both these hormones regulated the concentration of the calcium. One is increased, it means activated the osteoblasts and make the resorption of the bone. Second, decrease, vice versa, activated osteoblasts and make the deponization of the calcium inside of the bones, as you remember. You remember that the thyroid gland is located in the control of the pituitary gland, produced so-called thyrotropin. This is the hormone which is regulated activity by negative feedback loop reaction. Then T3, T4 produced less, thyrotropin hormone produced more. It is stimulated thyroid gland to produce more hormones. But I must speak now about topography. And first of all, I will remind you parts of the gland which you studied during your anatomy. Generally, it has 3 parts, sometimes 4. 3 parts, it is right and left lobes, and it is isthmus, which is located between them. 4th part, it is pyramidal lobe, which is usually ascending structure. It is goes to upwards, and in majority of cases, it was absent. For example, in this picture, you don't see pyramidal lobe. If it is presented, it is go from isthmus to upwards in the horn-shaped form. Yeah, this is called pyramidal lobe. Now, what topography? First of all, the projections of our thyroid gland into the skin of the neck region. Look here, please. Upper pole of the lobes of the thyroid, located approximately in the level of the midpoint of the lateral margins of your thyroid cartilage. So you copy thyroid cartilage, you find the lateral margin, in the midpoint of it approximately will be upper pole of your, for example, here you can see this consequence. That is your thyroid, that is the midpoint, and that is the superior pole of it, which is coming approximately to the midpoint level. Lower pole of your thyroid reach the level of the C7 approximately, even it can be a little bit less. By the way, if it is possible, put your left finger in your jugular notch. Do it. You do it, friend, do it. And put your right finger in the spinous process of your C7. Now tell me please, which your finger is higher, your left or right? Right is higher. Thank you very much. You can now look to me. It's really so. You know, posteriorly, border of your neck it is C7. Anteriorly, border of your neck it is jugular notch of the sternum, but they located not in the same level. If from jugular notch of sternum you will provide it horizontal plane, it will go to the level of T1, T2. not to the level of C7. C7 will be higher. Do you know why? Because your vertebra is not straight. It is curved. It has lordosis and it has kyphosis. You understand it or no? That's why it stands shorter according to the anterior borders. That's why neck is finishing the level of C7, but if from anterior side you will make horizontal plane, you will go to the thorax region, not to the neck region. This is important in the future. Now remember, please, after then I will speak about surgical intervention, we will mention this question. That is the case why your thyroid gland can descend it down up to the level of, for example, T1, but it still will be the neck region because from anteriorly it will be above the level of the jugular notch of the sternum. Situation is understandable? Very well, let's continue. As I, this is projection of the upper pole and projection of the lower pole. What the projection of your isthmus? Your isthmus generally projected by horizontal line, which is located in midpoint of distance between inferior margin of your thyroid cartilage and jugular notch of the sternum, here. Otherwise, I can say that it is located in the level of the third, fourth, tracheal semicartilages. You know, trachea has two main portions, cervical and thoracic. Cervical one located from the level of C6 up to the level of the jugular notch of the sternum. And it contains 6 semi-cartilages. Why I say semi-cartilages? Why I say semi-cartilages? Why I don't say just cartilage? Because from behind it is soft membrane. Your tracheal cartilages have the cartilaginous origin only from in front and from side. From behind it is soft membrane, which is touched to the anterior wall of your esophagus. That's a posterior wall, friend, some emotions, move your head, make some emotion, otherwise like the statue in front of me. Is it understand? That's a, you, during tracheostomy, you can simply damage posterior wall of trachea. Why? Because that is soft tissue. Imagine that you longly inserted, for example, scalpel to cut, for example, the cartilages. Simply tip of your scalpel can perforate the posterior wall and can make so-called tracheoesophageal fistula. And it will be very serious problem in the future. Why? Because we will have the situation which is called aspiration. What is the aspiration? Then the part of your tracheal, your esophageal content will come to the respiratory system. Slime, food, I don't know, water. It can come to the respiratory system with formation of the, in future, the pneumonias, of course. If the pieces of the food will go to the respiratory system, 100% it will give the inflammation in the future. With formation of the aspirational pneumonias. Aspirational pneumonias, which is very hardly treatable problem. Why? You give the antibiotics, problem is decreased, after 2 days the same picture. Because pieces of the food is not clean and washed from the respiratory system. And they will give forever this inflammational process until or you will endoscopically clean and wash, or touch wood, the patient will be dead. Let's say, remember please, once again, the isthmus of your thyroid gland located in the level of third, fourth tracheal cartilages. Let's say it will mean that first and second, your tracheal cartilages will be above the isthmus. 6th and 5th tracheal cartilages will be below the isthmus. And according to that, in the future you will see that you can make upper tracheotomy above the isthmus, middle tracheotomy in the level of isthmus, and lower tracheotomy below the level. So you can open trachea above, below, and on the level. Is it understandable? Very well, let's continue. This is about the projections. Now let's speak about syntopy. What is the relation of it to neighboring structures? In front of your thyroid, you have infrahyoid muscles. Primary is sternohyoid and sternothyroid muscle. One is go to hyoid, one second to thyroid cartilage. Behind of it, portionally, will be trachea behind of the isthmus. Portionally, it will be carotid neurovascular bundles. Behind of the lobes will be mainly, for example, you have two lobes, yeah? Will be carotid neurovascular bundle. More of this. Behind of the left lobe, we will have also esophagus. Why esophagus? Because it is left shifting structure. It is passed not strongly by midline like trachea. Trachea, it is midline structure. Esophagus, no, it is shifting to the left side. This is strongly behind of left lobe, except carotid neurovascular bundles. We can see also the esophagus. From sides, we will have the neck muscles. Primary, it will be the scalenus muscles, yeah? Deep muscles of the neck, which will be located from two sides of your thyroid gland. Yeah? Very well. Now, about some coverages. You know, your thyroid, like for example, I have now my white cord and my sheath. It doesn't fuse to each other. Thyroid has two capsules. First one, superficial, we call fascial. Second one, deep, we call fibrous. And again, it doesn't fuse to each other. Between them, there are loose connections. If you will look, by the way, to the posterior surface of your thyroid, you will see four parathyroid glands. They will be immediately between these two capsules, which I mentioned, between fascial capsule and between fibrous. That is the cause why we remove thyroid gland only inside of fibrous capsule, not inside of the fascia. Because if you will remove it by whole this fascial capsule, you will remove the parathyroid glands also. It will make the tetanus, it will make the muscular spasm up to the paralyzation and mortality, because the calcium level will be destroyed the blood. It is understandable for you. That is very important to remember this. For example, there are surgery which is called strombectomy, complete removing of thyroid gland. When you do it, inflammational problem, like for example, the toxical goiters, autoimmunity problems like the Hashimoto disease, but finally cancers of the thyroid. Cancer of thyroid, it is common form of the cancers, guys. By the way, much more usually we have benign problems of the thyroid. You know, after 15, any second person in human population have the benign thyroid cystic problems. Unfortunately, some of these cystic problems can grow up to their malignancy. Let's say that is big problem. That is, you can say, I don't want to say that it is like the pandemical problem, but anyhow, it is really near to it. Problems with the, especially 21st century, not because only we investigate it better and we find the problem, but of course, influence of the stress in our life, yeah, problems connected with pollution, big radiation, you know, the most sensitive structure of the human organism to the radioactive influence, it is thyroid gland. And you know that due to the development of the different kind of, for example, yeah, guns, I don't know, pharmacy, I don't know, some another branches of our life, level of the radiation is increased. Radiation level is increased. Nuclear stations, which also can be the risk of the high radiation level. Because I remember, please, thyroidal problem is very widespread nowadays, and I will teach you how to make the surgery into the thyroid gland. Let's continue now. Fascial capsule, which is older capsule of the gland, approximately in the level of the isthmus. Otherwise, it is the midpoint of the lateral margin of the lobes. Forms the suspensor ligament. Now look, behind of me, I will have esophagus. Yeah. Now I raise my hands and fuse with the esophagus. I think I forms the suspensor ligament. By author, we call it the Berry ligament. Very important ligament, because if you make surgery in the thyroid gland, you should cut this ligament to make mobilization of the gland because it is fixatory ligament. By the way, immediately under of these ligaments, we will have inferior thyroid neurovascular bundle, which is contain inferior thyroid vessels and nervus laryngeus recurrens, which is branch of the nervus vagus. Not in the level of the inferior pole, but in the level of the approximately midpoint. For example, look, that is inferior thyroid arteries. Look in which level they come. That is not the inferior pole. That is approximately midpoint level. For example, if you will look to the superior thyroid artery, you will see that it immediately comes to superior pole, but inferior one, no. That is also important surgical information because if you remove the gland, you should ligate it vessels. So you must know that if superior one immediately, by its name, yeah, if it's superior, it should come to the superior part of the gland, yeah, but inferior doesn't go to the inferior parts. So it comes approximately to level of the midpoint. Now, small information, maybe a review, we can say, of arterial supply, venous drainage, lymphatic drainage, and innervation. Arteries commonly is two. First we studied yesterday, then we discussed the carotid triangle. As you remember, I say that external carotid gives 7 branches, and one among of these branches, it is the superior thyroid. Superior thyroid supply not only thyroid gland, it gives superior laryngeal branch. As you remember, it is go to the larynx, supply the larynx, but finally it is reached the superior pole. By the way, it passed together with the nerve, which is called superior laryngeal nerve. Again, the branch of the vagus. Superior laryngeal nerve, as you remember from anatomy, split it into 2 terminal branches, external, internal. Internal sensory, external mainly motor, which is come not only to thyroid, it is goes to the cricothyroid muscles, yeah, cricothyroid membrane, cricoidal muscles, and supply them. This is laryngeal muscles, which is move your vocal cords. For the gland, it make the parasympathetic again in the innervation, as you understand. Inferior thyroid vessels, which you see in this picture, that is the branches of truncus thyroid cervicalis, which is the branch of subclavian. Subclavian, as you remember from anatomy, has 3 portions in the neck. First, inside of scalena vertical triangle, little will draw it together. Secondly, interscaleneous space, and third, in lateral triangle above the clavicle. First portion gives 3 branches. One among them, it is truncus thyroid cervicalis. It gives 4 branches. Inferior thyroid, suprascapular, ascending, cervical, and superficial. Critically important artery is inferior thyroid because all organs of the neck supplied by this inferior thyroid, not only thyroid gland, and the esophagus and trachea. It passes also not alone, it passes with recurrence laryngeal nerve, which I say before, again the branch of the vagus. And as I say, behind of the Barry's ligament, they enter from midpoint approximately of the lateral margin of the lobes, they enter inside of the gland and they meet the supply artery. Last artery which you see this midline ascending artery, that is arterial thyroidea E1. In majority of cases it was absent, more than in 80% it was absent. But if it is present, it is immediately, like in this picture, you can see or branch of brachycephalic or immediately from aortolarynx. As you remember, I told you yesterday that it's located inside of previsceral space between parietal and visceral layers of the fourth fish. It doesn't fuse with these fascias. Then you cut this artery, it is descended to superior mediastinum, and it gives the bleeding inside of the mediastinum. Finally, clots press the heart, finally they stop the heart, and the person was there. What to do to avoid it? Delegate this artery and cut it out. We can live easily without this artery, but it should be removed. About venous drainage, for example, in the by the way, in this picture, it's also visible, much more visible here, 3 pairs of the veins. Superior, middle, inferior. Superior and middle, as you can see in picture, immediately drain into internal jugular vein. Inferior one forms together the plexus. We call it plexus venosus thyroides impar, by the way, in same previsceral space. which is drained in brachycephalic or immediately into the superior caval vein. Usually it is left brachycephalic drainage. But finally, lymphatic drain, all organs, not only thyroid, drain into the jugular lymphatic trunk, which is passed along the internal jugular vein. This is the regional deep lymphatic nodes of the neck region. Along the internal jugular vein, we have the group of the lymphatic nodes. By the way, they drain finally in right side, in the right lymphatic duct, in left in ductus thoracicus, which is drained into your caval lemon system. That's all. About the innervation, sympathicus, parasympathicus, sympathicus, 3 ganglions in neck region, superior, middle, inferior, all gives the branches into the thyroid gland. Parasympathetical nerves, I told you, 2 branches of your vagus, superior laryngeal or nervus laryngeus rectus. That is all innervation. Second organ which I want to introduce for you, of course, it is trachea, your lower respiratory system, together with bronchi. Your trachea has 2 parts, cervical and thoracic. Cervical part now we will discuss, thoracic part located in your superior mediastinum. By the way, if it is possible now, please palpate the angle of your mandible. Angle of your sternum. It's located immediately between manubrium and between body. Very well palpatable structure. Everybody can palpate it. Now look, if you will provide it horizontal plane from that level, it will be bifurcation of your trachea. So remember forever, bifurcation of your trachea located strongly in the level of T4, T5. Otherwise, horizontal plane, which is passed from the angle of your sternum. Here trachea is finished. And 2 main bronchi. Right, it is wide and short, it is continuation. That's why in majority of the cases, if there are foreign bodies of trachea, it is distended in right one. It's this continuation of the trachea. And the left, which is narrow and longer, which is going to the left lung. Now, cervical trachea started from the level of your C6. What is C6? C6, it is inferior margin of your thyroid cartilage. Larynx is finished, trachea is starting, and from this C6 it is come up to the level of your T1. Otherwise, jugular notch of the sternum. This portion which you see now between my 2 fingers, we call cervical part of the trachea. By the way, your trachea pass not only from up to down, but your trachea pass also. Palpate your trachea and say how it pass, not only from up to down, but also. You're right, just try to explain. From superficially to deep. From superficially to deep. That's it. The more upper you will open trachea, the less tissues you will cut. Vice versa, the more lower you will open trachea, the more. That's why. Do you remember 2 minutes before I told you that tracheotomy can be superior, middle, inferior? The more inferior you will do, the more dangerous it will be, because the more tissues you will cut. And after, of course, we will study. But now remember, trachea pass not only from up to down, but from superficial, like my hand. That's how you can simply palpate it upper parts, but hardly palpate it lower part, because it is go very deep. Very well, now let's speak about, like previously, about projections, about the syncope, and about all that. Projection is so simple. Midline of the neck, from the level of the C6 up to the level of the T1. It is on syncope and skeletotopy in the same time. Like holotopy, sorry. Like holotopy, you can say, sorry, but it's invisible. Here is our word, for example, C6. C6 is invisible, but you can simply palpate it inferior margin of your thyroid cartilage. It will be the same level. Samely for T1, it is not visible, palpatable, but you can simply palpate it jugular notch of your sternum. Let's say to say from C6 to T1, it is same to say from inferior margin of thyroid cartilage up to the jugular notch of the superior margin of the jugular notch of the sternum. It will be holotopy and skeletotopy in the same time. How about syncope? In front of your trachea, we will have isthmus of thyroid, we will have infrahyoid muscles, which we described before. from two sides of your trachea will be the same carotid neurovascular bundle. By the way, the most near structure will become carotid artery. Look, I don't say common carotid artery with its branches. Why? Because common carotid artery split it into the branches by upper marginal thyroid cartilage. Here we don't have trachea. Near the trachea you will have not the branches of common carotid, but you have main trunk. Branches of common carotid originated in the level of larynx, not in the level of trachea. By the way, you remember this syncope of elements. Medially common carotid, laterally internal jugular, between us and little bit behind nervus vagus. This is simple. What is behind of your trachea? Partly esophagus, partly the vertical. Because esophagus little bit shifted into the left side, as I say. Supplement is absolutely same to what I say for thyroid. Yeah? Inferior thyroid vessels and nervus laryngeus rectus. Parasympathetical nerves. Sympathetical nerves come from three ganglia. Asa, not a